Thank you, madam. Right at the outset, I'm grateful to the PCOS Society, Dr. Duru Shah, Dr. Madhuri Patil, and team for inviting me. The topic possibly smells of Madhuri in the sense it says progesterone therapy in the first trimester. What is the best protocol? I think the first thing is that in medicine, base changes. So what I will try to do is to go through, look at the current evidence and say that what is the best protocol as of today. And some landmark study might come out and change our perception completely in the next 1 year. What I will be speaking on is the role of progesterone in the first trimester in idiopathic recurrent miscarriage and the role of progesterone in the first trimester in threatened miscarriage. A normal pregnancy, there is no role of progesterone, so I will skip that. Luteal phase support is a completely different topic, but I will not do that. But it's a good idea, people who are on luteal phase support, you continue the same progesterones in the first trimester. I will start off with the role of progesterone in idiopathic recurrent miscarriage without getting into what are the hypotheses. We all know progesterone is an essential hormone of pregnancy, and we know that many a times a deficit of progesterone will cause a miscarriage. But in medicine, many a times when we know that a deficiency of something causes a problem and we've not been able to show that adding that externally improves the outcome. And that is true very much of progesterone down the years. Now, one of the theories in unexplained recurrent miscarriage that there's an abnormal immune response of the mother to the paternal antigen of the fetus. And immunomodulation might hold a key to a successful pregnancy outcome in the sense that progesterone might be able to alter the balance between Th1 and Th2 helper cells, which will determine whether the pregnancy will continue normally or whether it would end in a miscarriage. With that bit of introduction, I will straight get into the evidence. And the earliest evidence that the systematic review of 2013 published in the Cochrane database, this looked at 14 randomized controlled trials or quasi-randomized controlled trials, which included over 2,000 women. And it looked at the role of progesterone to prevent miscarriage. And they found that for an unselected population, in the first trimester of pregnancy, there is no evidence of benefit of progesterone usage for preventing miscarriage. There was no evidence to support the use of progesterone routinely in a normal pregnancy. And that's very important. Every study has shown that. But what was interesting is that in a subgroup analysis of 4 of these studies, which included over 200 women, it showed that there was a significant decrease in the miscarriage rate with progesterone treatment. But they could not make a recommendation on which progesterone, by which route, and by which dosage, because all these 4 studies had used different progesterones in different dosages and by different routes. So they made a recommendation that treatment for women with recurrent miscarriage with progesterone is warranted, but they did not make a recommendation on which progesterone. Now, all of us were waiting with bated breath for the PROMISE trial. And the PROMISE trial was one of the largest trials of progesterone in early pregnancy. And this was a multicentric trial in 36 centers in UK and 9 centers in Netherlands. And it was a double-blind randomized placebo-controlled trial where women with unexplained recurrent miscarriage, who had 3 or more miscarriages, were randomized to receiving vaginal micronized progesterone 400 milligram twice daily or a placebo. And this started as soon as the pregnancy test was positive. And the primary outcome was live birth after 24 completed weeks of gestation, and there were various secondary outcome measures looked at. We were all very surprised when the results of PROMISE trial was published, and it showed there was no difference in using progesterone or using a placebo in terms of live birth rate or miscarriage rate or stillbirth or neonatal outcome. It was very, very surprising. And they concluded that progesterone therapy in the first trimester of pregnancy did not result in a significantly higher rate of live births among women with a history of unexplained recurrent miscarriages. To the extent that people who've done this did this study and they said, don't look at any other progesterone. This is the class effect. So there's waste of time giving progesterone. What was surprising, the same year that the PROMISE trial was published, in Fertility Sterility, this paper was published, which did a luteal start of vaginal micronized progesterone to improve pregnancy success in women with recurrent pregnancy loss. And they continued the progesterone till 16 weeks of pregnancy. And they found that there was a benefit with vaginal micronized progesterone in decreasing the miscarriage rate. Same year, again, this study was published, which again is a randomized controlled trial in unexplained miscarriage, and an RCT with 350 women in each arm, pretty robust numbers. And again, they used vaginal micronized progesterone or placebo, and they showed the use of vaginal micronized progesterone halved the risk of miscarriage in women with unexplained recurrent miscarriage. Completely contradictory to what the PROMISE trial concluded. Now, there were some criticisms of the PROMISE trial. The first criticism is that women with unexplained recurrent miscarriages were randomized with a positive pregnancy test without checking for viability. So some of these women might already have miscarried by the time they went on progesterone, and that might have skewed the results. Number two, the progesterone was continued till 12 weeks, and maybe the 12 weeks was not enough. That is just a suspicion. And this is a study which was published from India, from Maulana Azad Medical College, Dr. Ashok Kumar. And what he did was 18 to 30 women in the age group of 18 to 35 with three or more miscarriages. And after checking for a positive fetal heart, he randomized them into either dydrogesterone 10 milligram twice a day till 20 weeks or placebo. He had 180 women in each arm, and he showed that the miscarriage rate decreased from around 17% to around 7% with the addition of dydrogesterone. Till date, this remains the most robust trial for the use of dydrogesterone in unexplained recurrent miscarriage. There is a systematic review of dydrogesterone published in 2015, which had 2 randomized controlled trial and 1 non-randomized comparative trial, and both showed there was a benefit with using dydrogesterone in unexplained recurrent miscarriages. Now, this meta-analysis of progesterones in recurrent miscarriage was published in 2017 in Fertility Sterility. It looked at 10 randomized controlled trial of around 1,600 women, and it showed there was a lower miscarriage risk with the addition of progesterone in women with unexplained recurrent miscarriages, higher live birth rate, but they found only synthetic progesterones were useful. What is the best protocol? I will say that at the end. So what we can see is that at the present moment, oral dydrogesterone started after a positive pregnancy test, after a positive fetal heart, in women with unexplained recurrent miscarriage, it decreases the miscarriage risk. The data is not so robust with vaginal micronized progesterone, but if you start them in the luteal phase and then continue it into pregnancy till 16 weeks, 2 studies have shown some benefit. So what about threatened miscarriage? Now, threatened miscarriage in women, there were 3 studies of dydrogesterone. Now, there is a problem with these 3 studies of dydrogesterone. Again, the problem is one of these studies used a loading dose of dydrogesterone of 40 milligram. The other 2 studies didn't. All these 3 studies put the women on dydrogesterone 10 milligram 2 to 3 times a day. Now, one of the studies stopped the dydrogesterone as soon as the bleeding stopped. The second study continued the dydrogesterone till 1 week after the bleeding stopped, and the third study continued the dydrogesterone till 12 weeks of gestation. And what they found in all these 3 studies, that there was a reduction in the miscarriage risk with the addition of dydrogesterone in threatened miscarriage. Based on this, in 2013, the Ranzo guidelines said that miscarriage was significantly less likely to occur on progestins than placebo or no treatment. And obviously, the data was with dydrogesterone only at that point of time. Now, in August 28, this Cochrane review was published for progesterone in threatened miscarriage. It had 6 randomized and 1 quasi-randomized trial of 696 women, and it showed progesterones did reduce the risk of miscarriage, but oral progesterones reduce the miscarriage risk. By oral progesterone, we mean dydrogesterone. Please remember, we are only talking of dydrogesterone and vaginal micronized progesterone. We are not talking of oral micronized progesterones, because there is very little data on that, and that is not a physiological way to give progesterones. They showed that oral progesterones reduce the miscarriage risk, and the vaginal progesterones have little or no effect. Does that mean that this is we've written the obituary of vaginal progesterones in threatened miscarriage? Possibly not. And the PRISM trial was published in 2019 by the same group who did the PROMISE trial. And this was a randomized controlled trial of over 4,000 women under 39 years who came in with early pregnancy bleeding across 48 hospitals in UK. There was one difference with the PROMISE trial. This time, Viability of the pregnancy was an inclusion criteria. So they included women only with a viable pregnancy, and very logically they excluded women with massive bleeding or who are hemodynamically unstable. So about 2,000 women received vaginal micronized progesterone 400 milligram twice daily, and the other 2,000 received a placebo. They showed, when they looked at the entire data, there was no improvement in live birth rate in over 34 weeks. Again, when they stratified the data in women who had no past history of miscarriage and presented with threatened miscarriage, given them vaginal micronized progesterone was of no benefit. But the interesting data was that in further subgroup analysis in women who had previous 1 or 2 miscarriages, there was a 4% increase in the live birth rate with vaginal micronized progesterone. And women who had previous 3 or more miscarriages, there was a 15% increase in the live birth rate with the use of vaginal micronized progesterone, which means that vaginal micronized progesterone has a role in women with threatened miscarriage, in those women who've got a past history of a miscarriage. A cost effectiveness analysis of the PRISM trial was done, and which was showed that you get for a small additional cost in the UK at an additional cost of £200, which is minuscule compared to their pregnancy cost. The progesterone was associated with a positive impact. And the same study was replicated in US, and that also showed that there was a benefit, based on which in early January 2020, the Royal College came out with its press statements that in UK alone, progesterones could prevent about 8,500 miscarriages in a year. Very significant numbers. Is progesterone safe? We've had issues with some anecdotal studies coming in and looking at saying that there is an increase in cardiac anomalies in mothers who've received dydrogesterone, increase in renal anomalies in patients who've received micronized vaginal progesterone. When you pull that into larger databases and larger studies, there's one published just this year, and there is no increase in congenital anomalies compared to the background risk, whether with dydrogesterone or with vaginal micronized progesterone. The ASHRAE 22 guidelines say that vaginal progesterone during early pregnancy has no beneficial effect in women with unexplained RPL. That is today. We might speak differently in a few years' time. There is some evidence that oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. Furthermore, as progesterone is important during implantation of the embryo, benefit from supplementation may be realized if progesterone is administered from the luteal phase rather than after a positive pregnancy test. And they've said more trials are needed to evaluate oral progesterone administration of progesterone from the luteal phase. So to take home messages, there is no role of progesterone to prevent miscarriage in a normal pregnancy. So do not write a progesterone in a normal pregnancy thinking that it will reduce a miscarriage risk. There is a moderate quality evidence of benefit of progesterone use in threatened miscarriage, and there is moderate quality evidence of benefit of progesterone use in unexplained recurrent miscarriage. So that brings us to the question, what is the best protocol currently? In unexplained recurrent miscarriage, dydrogesterone 10 milligram twice a day started after the fetal heart rate is established till 20 weeks of gestation. Now, why 20 weeks? Maybe 14 weeks is enough, maybe 16 weeks is enough. But the trial which has the highest numbers used it till 20. So at the present moment, we'll have to say that use it till 20. And so which means very easy to remember, dydrogesterone 20 till 20. In threatened miscarriage, dydrogesterone 10 milligram twice a day or thrice a day, maybe it's a good idea to give it thrice a day. Now, how long you want to give it? Till bleeding stops, or 1 week after the bleeding stops, or till 12 weeks of gestation is your choice, because there are 3 studies which used it differently. And some studies use a loading dose of 40 milligrams, so you might want to use that. And women with recurrent miscarriage, presenting with threatened miscarriage, vaginal micronized progesterone 400 milligram twice daily is effective, provided the patient is willing to take vaginal medication in the place bleeding. Unfortunately, in India, we practice in a situation that we have friends practicing in the neighborhood who will go back and tell the patient that you miscarried because somebody given you a vaginal tablet when you are bleeding. And that just adds to problem. Behind every successful litigation, we have a friend working behind it. Thank you very much.